So it's my great pleasure and to invite my colleague and friend Mohammed Elharari from Tawam Hospital. He's one of the senior consultant cardiologists established. Actually, he's the founder of the heart failure clinic in Al-Ain, whole Al-Ain. We learn from him. He will talk to us about heart failure and diabetes. Dr. Mohammed.
Assalamu alaikum wa rahmatullahi wa barakatuh. I hope you can hear me. It's my pleasure to be here, and I'd like to thank Prof. Shihab and the organizing committee for inviting me to this meeting. The title I was given is Diabetes and Heart Failure. I must confess that I'm not a diabetologist, but as a general cardiologist with interest in heart failure, you get forced to learn more and more about diabetes, and as probably every cardiologist have to. Okay, so what I'm going to talk about, I'll talk about the prevalence of diabetes and heart failure, the bidirectional relationship between diabetes and heart failure, a diabetic medication that reduce the risk of cardiovascular death and heart failure, the treatment of heart failure in diabetic patients focusing on SGLT2 and ARNI. So heart failure, is very common with prevalence up to 5% in some countries, and this is increasing all the time with probably constant higher morbidity and mortality. Diabetes even commoner with general prevalence of 6.6%, although this is very variable between countries, and you see from this map the countries in the very dark blue have a prevalence of more than 12%. And this involved the Gulf country. And I think the prevalence in UAE in 2019 was 19%, and numbers predicted to reach 2 million in 240 in this country. It's a very common problem. Having diabetes is bad for you. Having had a diabetes as if you had a myocardial infarction without diabetes, you really survival comes down. And if you have both, if you had diabetic, had myocardial infarction, then your prognosis is worse. Now, if you get older, like I am, and you get overweight, and you don't do very much sedentary life with a little bit of bad genes that you cannot control, then you develop insulin resistance. And this leads to dyslipidemia, hyperglycemia, hypertension, hyperinsulinemia, and this will affect your endothelial dysfunction and lead to cerebral, peripheral, and coronary artery disease. And the relation between the heart failure itself and the diabetes is, as I mentioned, is bidirectional, which means that the presence of one of them increased the risk of having the other one, and made the presence of both of them make the prognosis of the other one worse. So for diabetic people, the risk of having heart failure is 2.5 times compared to the non-diabetics. And for every 1% increase in your HbA1c, you have an 8% risk of developing heart failure. And diabetes increase the risk of heart failure predominantly through the increased risk of coronary artery disease and the subsequent progression to post-ischemic heart failure. But also, it has a distinct entity, quote unquote, called diabetic cardiomyopathy, which occurs in the absence of epicardial coronary disease, hypertension, or significant valvular heart disease. On the other hand, having heart failure itself will increase your insulin resistance and lead to development and worsening of your diabetes. And the risk of having diabetes in patients with heart failure is 1.5 times higher than those without heart failure. Now, the pathophysiological link or mechanism is poorly understood, but the belief is that this related to the altered free fatty acids, the neurohormonal abnormality, the RAS, the microvascular dysfunction, cardiac autonomic dysfunction that lead to myofibrosis, impaired contractile function, LVH, myocyte necrosis, etc., that lead to cardiomyopathy, heart failure, which subsequently lead to insulin resistance, and you go into this vicious circle of worsening the other. It is well known that in heart failure, presence of diabetes significantly increase the risk of hospitalization, death compared to patients without diabetes. This is on the left side is the data from the CHARM trial showing that patients with heart failure and diabetes do much worse than those with heart failure without diabetes. And some data from the paradigm heart failure itself showing that with each increase in HbA1c, the prognosis gets worse. So not just having diabetes, how bad is your diabetes? The worse your diabetes control, the worse your prognosis. And the increase in HbA1c now is recognized as itself as an independent risk factor for development of heart failure. And for every 1% increase in HbA1c, the risk of cardiovascular event and death in heart failure increased by 25%. So increasing HbA1c in your diabetic heart failure worsen their prognosis. Not only in diabetic, this relationship was evident in heart failure with or without diabetes, with preserved and also with reduced ejection fraction. These are data from the CHARM trial showing that. Now, the Diabetic Guidelines, the latest one to 2019, recognized that and identified 3 groups of drugs that have been sort of safe and probably preventative and for diabetic patients for development of cardiovascular event and or heart failure. The 3 groups are the SGLT2 inhibitors, the glucagon-like peptide 1 receptor agonist, and the DBB4 inhibitors. Now, just a quick word about on this graph. Really, for the first 2 groups, GLB1 and the DBB, is the center of the treatment is the glucagon-like peptide 1, which is the good guy. This is the good guy that's normally secreted by our intestine, by our bowel when we eat a meal, and does good things. It stimulates the liver to increase the insulin and reduce the glucagon, and it decrease the gastric empty, increase our satiety and decrease our weight, so it improves hyperglycemia control. So we can have more of that by 2 ways, either by injecting ourselves with glucagon-like peptide 1 receptor agonist, which is the group on the left side, exenatide, liraglutide, deplectide, dulaglutide, semaglutide. The last one has oral, it can be given orally as well. Or by giving drugs that inhibit the destruction of the GLB1, the natural GLB1 we have in our body, which is the group of drug on the right side, the saxagliptin, the linagliptin, the vilactiptin, the others. So just moving on. So the last group, which is DBB4 inhibitors, has been shown to be safe in diabetic patients at high risk of developing 3-point MACE, which is cardiovascular death, non-fatal MI, or non-fatal stroke, and also safe, i.e. safe means they don't increase the risk, and also relatively safe and not increasing the risk of heart failure, except the saxagliptin, which has been shown to increase heart failure and therefore is contraindicated in this group. Now, the other group which does better than the DBB4 are the GLB1 receptor agonists. These drugs have been shown actually to reduce the risk of 3-point MACE, of non-fatal death, non-fatal MI, non-fatal stroke, if given, but they were neutral as far as heart failure. So they don't increase it, but they don't decrease it. So, and the liraglutide, it does reduce risk of death on top of preventing the 3-point MACE. The group that does best are the SGLT2 inhibitors, which have been in diabetic patients at high risk. Not talking about heart failure. The diabetic patient with established coronary disease or high risk of cardiovascular disease. And these 3 drugs, the MBA, the CANA, the DABA, have been shown in large major trials to reduce cardiovascular death or heart failure hospitalization significantly. And the MBA and the MBA-REG actually reduce mortality by 38% on top of that. So these are the best drugs to give. This has led to the guidelines really promoting this group of drugs, the SGLT2 inhibitors and the GLB1 receptor agonists, to be in first-line therapy in diabetic patients with established or high risk of cardiovascular disease instead of metformin. What about the treatment of heart failure in diabetic patients? This is really, it's not different. So you treat them as you treat the non-diabetic. So to go back to this, the 4 pillars of ARNI, beta blockers, MRA, and SGLT2. So you treat them with the same drugs as been explained throughout this meeting. Just a couple of words about the SGLT2 inhibitor trials. You're all aware of the DABA and the DABA heart failure, the Emperor reduced trial, which showed without doubt that the use of EMBA or DABA in patients with ambulatory patients with class 2 to 4 heart failure, whether they are diabetic or not, that they meet the primary endpoint of cardiovascular death or heart failure hospitalization. A quick word about this Soloist trial, because it has just a couple of interesting things. So this studied the sotagliflozin. The sotagliflozin, in addition to being SGLT2 inhibitor, it's also SGLT1 inhibitor, which works in the gut to reduce the absorption of reabsorption of glucose from the gut. That's one thing. And this study has been studied only in diabetic, but this study studied patients with worsening heart failure, including inpatients. And this is also across all ejection fraction. So the 2 points from the study that it meets its primary endpoint of reduction of cardiovascular death, heart failure, hospitalization, and urgent heart failure visit, but it showed, they demonstrated that it's safe to be given as an inpatient, and it also give us a hint that maybe this group of drug works in people with preserved ejection fraction. And this also been confirmed 2 weeks ago by the Preserve trial, which you all know about now, that studied heart failure with reduced ejection fraction and ambulatory patient 2 to 4 NEHA class, regardless of the ejection fraction, with ejection fraction more than 40%, regardless of being diabetic or not. And again, it meets its composite endpoint of death or heart failure hospitalization. And with number to treat only 31 patients. And now this is obviously now in the guidelines, which released again a few weeks ago, the DABA and EMBA are class 1A recommendation for HFrEF patients. And just 2 days ago, the FDA granted EMBA the breakthrough therapy designation for heart failure with preserved ejection fraction, which is the way of it being approved by the FDA. Now, what about the use of ARNI in diabetes? I know it is, one of the class we should use. Is there any data in diabetes? I'm not going to go through the paradigm study itself, which is really a marvelous study for all HFrEF patients, comparing, sacubitril fulsartan versus enalapril, showing really it meets all the points, including death, sudden death, forever, heart failure, hospitalization, everything. But it's worth pointing that 34 patients in the paradigm were diabetic. Not only that, actually, it's been found that the effect or the benefit of sacubitril fulsartan in diabetic is actually twice in the non-diabetic. So actually, it is the diabetics get twice the benefit compared to the non-diabetic from having sacubitril fulsartan in HFrEF patients. Now, also in post-hoc analysis from the paradigm study, it was noted that the sacubitril fulsartan does significantly reduce HbA1c compared to enalapril in diabetic patients. So, in summary, ladies and gentlemen, as I mentioned, there's a bidirectional relationship between heart failure and diabetes. Presence of one of them increases the risk of the other one, worsen its prognosis. Type 2 diabetics with moderate to high risk, GLP-1 receptor agonists reduce the risk for cardiovascular events. SGLT2 receptor SGLT2 inhibitors does the same, but also reduce the risk of heart failure. And now these drugs are first line treatment for type 2 diabetic patients at risk having cardiovascular disease. Treatment for heart failure in diabetic patients is similar to those who are not diabetic, with the 4 pillars that we mentioned: ARNI, stroke ACE, beta blockers, MRA, SGLT2, and this is class 1 recommendation as per the new recently released European Society Cardiology Guidelines. So sotagliflozin, as I mentioned, has shown to be safe and effective in managing diabetic patients with heart failure for patients with worsening heart failure, including hospitalized patient across all range of ejection fraction. And the EMBA Preserve, the EMBA has shown to be effective in patients with heart failure with ejection fraction more than 40%. And as I mentioned in the last couple of slides, the magnitude of benefits of ARNI in heart failure in HFrEF patient is twice in diabetic compared to the non-diabetic. And the data from Paradigm suggests that ARNI improves glycemic control and in diabetic patients with reduction in HbA1c. As a cardiologist, really, what we should do, really, as part of risk factor assessment, like we do with the statins, BMB, whatever, we should check and monitor HbA1c. We don't have to leave it to the diabetologist, and ensure appropriate treatment to reduce it to target level below 7%. And thank you.
Excellent, Dr. Mohammed. As a heart failure expert, what's your percentage of diabetic patient in your cohort?
Well, a lot. I mean, I don't have data, but I might guess like 40%,
40%.
40%.
So when you get these patients already on hypoglycemic medication, and you know from the data there are some medication, worsening the heart failure, how you go about it? I mean, what you communicate with your diabetologist, or you switch them to one you think more appropriate? What do you do?
It's not an easy subject, really, because if patients sometimes they get even diabetic medication from completely different hospitals. Sometimes even don't show them to you, and I keep insisting you have to bring your medication with you. But I tell them, if I can't communicate if the diabetologist in my hospital, I communicate with them directly. But I tell them to really to stop, and I'm being fortunate in my current and previous hospital in UAE that we get freedom, so I can prescribe MBA, DABA freely. The problem obviously is just educating the patients. It's the polypharmacy. You're adding another tablet. You're not a diabetologist, and so on and so forth. Some patients accept this easy. Some have difficulty. Sometimes but anecdotally, we find this, and use IMBA more than DABA because of the availability. But it does work, and has been alluded to in this conference. This is a drug you can give. It doesn't reduce your blood pressure. It doesn't affect your electrolytes. A little bit diuretic effect, and so it's easy to administer. It doesn't need titration. And I routinely every visit I check part of the screening, the whole thing, the lipids, the HbA1c. I just do it routinely, even for the non-diabetic.
Thank you, Dr. Mohammed, for this great presentation.